next, I'll stop and let him talk. But my understanding is this is the first of a series of telemedicine talks that will be run by ALSF. They're Alex talks, I guess you could say. And Jay asked me to give one, and I said I was happy to. So I'm going to talk about cancer predisposition, and I'm going to start sharing my screen, and then I'll give my introductory remarks. Let's see if I can minimize this up here. Okay. So I'm talking about cancer predisposition in children, and the concept that this is an area that's growing in awareness of how important it is. I'd like to put it in brief context, and that is that we've come a long way in treating children with cancer, and we're curing 80%, and that's wonderful. The problem is we sort of plateaued, and it's going to be difficult to cure the last 20% or so. And also we're experiencing a lot of toxicity in those that we do cure, particularly those with high-risk disease. So the more we look, the more we see, but clearly we need, I would say, more effective, less toxic therapy. There are a number of approaches to doing that. One is with targeted drugs, one is with immunotherapy, whether it's CAR T cells or antibodies or vaccines or whatever. Another way is with targeted drug delivery, which I won't talk about today, but I could talk about in the future. Unfortunately, only a small fraction of the drugs we give actually get to the tumor, and I think we need to be smarter about how to get drug to the tumor. But another way to achieve sort of the same goal, to have more effective, less toxic therapy, is to pick up tumors early when they're small, more easily resectable, require less therapy, less likely to be metastatic, and have a better outcome. And so with less therapy, there'd be fewer side effects. So it's more effective, less toxic. And that is by identifying the increasing subset of children that we now appreciate have predisposition to develop cancer. I don't have a slide on this, but I have no conflicts of interest or anything to disclose regarding this. So there seems to be a bit of a delay in slide progression. There we go. So previously, at least when I was in training and for a long time after, we thought only a very small fraction of children were actually predisposed to get cancer due to a germline predisposition or germline change. However, we now understand this number is much greater. There are more predisposition syndromes have been identified. Very importantly, the sequencing of tumor tissue has identified mutations in predisposition genes that were not anticipated. And as a caveat to that, I think more and more people are doing paired normal tumor DNA in order to interpret the changes in the tumor DNA as to whether they're inherited or acquired, but it also gives us more insight into there being germline changes that may have been responsible for the cancer that the child has that we're dealing with. So there are several studies I'll show on the next slide that suggest at least 10 or 15% of children with cancer are predisposed. And I think this is likely an underestimate because there are children who have a predisposition syndrome but don't have changes in the anticipated genes, such as juvenile polyposis. Only a minority of children with juvenile polyposis syndrome have changes in SMAD4 or BMPR1A, which are the two genes that Jim Howe first associated with this syndrome. There also are inherited patterns in families like multiple members with Hodgkin disease or something where we don't even know a gene to look at. So there are genes to be discovered. There also are likely lower penetrance genes that don't stand out on a Manhattan plot or something, but may be contributing significantly to predisposition. There's some genes that, some diseases may be multigenic. Certainly recessive is another possibility. So there may be combinations of genes of the same or a different type that can predispose in aggregate. And finally, there are epigenetic changes, which we know about in terms of at least Beckworth-Wiedemann, which we'll talk about briefly. So I'm going to go to my laser pointer here. Yay. So here are some of the recent studies that have been reported starting in 1915 to 1918. And if you look here, the prevalence and then the family history is shown below, but the prevalence of a predisposition gene in series that were sequenced by Modi, this very large one from St. Jude by Zhang, and Will Parsons and Harris and Oberg and so forth. You can see they range from 9.9 to 10, 12, up to 20%. And in general, 40 to 60% will have a family history, but clearly not all. In some cases, it wasn't stated. So there are some caveats with this. If you look at the genes that have been identified, you can see that in most studies, TP53 or Li-Fraumeni syndrome is the gene most commonly involved. And it is actually the most commonly involved gene in adult cancer in terms of somatic changes, but it's a very prominent player in pediatric cancer as well. There are other genes that stood out as the most common, such as APC, but TP53 is also there. In this study, DICER1, but also TP53. If you look at the series of genes that were identified, you also see there are genes that we don't normally such as BRCA2. So it may be that there is a subset of patients, maybe with specific changes in BRCA1 that are predisposed to certain childhood cancers. And that's something we're still trying to sort out. So these other genes may inflate the numbers a little bit, but based on what I said in the previous slide, there's still a lot more to be discovered. So I think these numbers are reasonable estimates of what we may be ultimately looking at. So in this slide, you see the services that are provided by cancer predisposition programs. And there are a number of large ones around this country, as well as in Canada and throughout Europe and other places as well. But if you look at the family histories that many pediatric residents and fellows and even pediatricians take, they're usually not very detailed. They talk about the parents and the siblings, and they may or may not go to grandparents, but usually not much more beyond that. So it's good to take a very detailed family history and ask a lot of questions and a good physical exam, but we do that, and then we perform genetic testing plus both pre and post genetic counseling, so families know what the test is going to do and what its implications are. If someone's positive, we coordinate testing for other at-risk family members. So if a child is positive, we coordinate testing for the parents. If they're positive, we do the siblings, and whichever parent is positive, we try and do their siblings and the children of their siblings and the grandparents and so forth. We also recommend cancer surveillance based on the diagnosis and the risk according to international consensus guidelines. So a number of people were involved in a workshop held in 2016, sponsored by ACR, to develop guidelines for many of the more common predisposition syndromes. And the link to that is shown on the bottom, and I'll talk about that again in a second. We also provide referrals to subspecialties as needed for surveillance. So a lot of the surveillance is physical exam, blood tests, imaging like ultrasound and MRIs. And in other cases, additional imaging additional assessments are needed, such as those with GI cancer predisposition. They need to see the gastroenterologist. For those with thyroid cancer, they're better off being followed by thyroid disease experts in terms of evaluating nodules, whether or not they need to be biopsied, and also following the chemistries that go along with that. Or for retinoblastoma, seeing the ophthalmologist on a regular basis. So we coordinate that. And then if cancers are detected by this screening, they're referred to the oncologist for further therapy. So what are the reasons to refer a patient to the cancer predisposition program? So if an individual does not have cancer, you're pretty much stuck with two things. One is a family history of cancers that suggest a pattern or a syndrome. And the second is physical features of a predisposition. Have ALA spots, hemihypertrophy. Spots would be FAP or juvenile polyposis. CAF-ALA spots can be several things, but most notably neurofibromatosis, hemihypertrophy, Beckwith-Wiedemann, macrocephaly, ADD is P10 syndrome. If an individual has cancer, in addition to these features here, there are other features, such as if they have bilateral or multifocal primary cancers, or multiple primary cancers, more than one of a different type. So one has to be careful when you're talking about multifocal cancers to distinguish new primaries from metastases. In most cases, that's not too hard, like bilateral adrenal glands, but if you have disease in the chest and an adrenal primary for neuroblastoma, for example, it may be hard to tell, is that a lymph node or is that another primary tumor in the thoracic ganglia. Earlier than expected age is not that specific, but it certainly goes along with predisposition, particularly if you see an adult cancer, say a colon cancer in a child, or certain cancers like pheochromocytomas and so forth. There also are specific types of syndrome-associated cancers, which you'll see on the next table. And then the tumor profiling, as I mentioned before, can be suggestive of mutated genes, particularly if they're, in addition, doing the germline DNA as a comparison. So here is a table of the some of the diseases, the cancers that are strongly associated with a predisposition syndrome. It's not in everyone necessarily, but it's in a substantial number. So for retinoblastoma, we know that 40% overall have a predisposition syndrome, and so 40% of 100 and 30% of 100 will be bilateral. We know about a third of patients with rhabdoid tumors will have germline changes in SMARCB1 or SMARCB4 less commonly. The majority of patients with pleuropulmonary blastoma, 70% maybe, will have a germline Dicer1 change. Most patients in childhood with adrenocortical carcinomas will either have Li-Fraumeni or Beckwith. Patients with pheochromocytomas, the vast majority, over 80%, will have one of several syndromes, either multiple endocrine neoplasia, type 2A or B, with RET mutations, NF1, Von Hippel-Lindau, or the pleuropulmonary blastoma, the pheochromocytoma paraganglioma syndrome. There are 7 genes that cause that, and 4 or 5 of them are in the SDH family. Medullary thyroid cancer, almost all patients with that, according to our endocrinologist, will have MEN 2A or 2B. And then for Li-Fraumeni syndrome, the majority that have choroid plexus carcinomas and anaplastic rhabdo, a lot of them will have germline changes, and there are others as well. So this is a bar graph of the types of patients we've seen over the past 12 or 15 years. And after we sort of got a slow start to our program and then got going, but you can see we do not see patients with NF1 and NF2. They're seen in a separate program, and patients with bone marrow failure are similarly seen in a bone marrow failure clinic. So Fanconi's anemia, Black Van Diemen, Niemogen breakage, all those things. So these are the syndromes, and if you sort of draw a line here, these are the more common disorders we see. And you can see retinoblastoma, sorry, for us, is The most common, in part because we've been a long-standing referral center for these patients with Wills Eye Institute, and Anna Meadows is here and so forth. Beckwith-Wiedemann, also very high, and this is probably in part due to having Jen Kalish here, who's an expert in this particular area. Li-Fraumeni, we see a substantial number, familial adenomatous polyposis and juvenile polyposis, the P10 syndrome, paraganglioma syndrome, multiple endocrine neoplasia, Peutz-Jeghers, the Noonan RASopathies, this is Gorlin syndrome, and then Dicer 1. So those are our top 12, and that's excluding, as I said, the ones you'd see down here, because NF1 would be off the charts if that were included in this particular chart. So when I mentioned this workshop we had, and this sort of summarizes, I'm not going to go into detail with this, but this summarizes the 60 or so most common disorders and the related genes that we addressed in this, and we broke them into these categories here on the side. And this was published in 2017, along with all the other related papers on recommended surveillance protocols, and these should all be open access. So this just distills that down to the more common things. The same groups, though, Li-Fraumeni was its own subset, and there already had been criteria established by David Malkin and the Toronto group, and sometimes called the Toronto Protocol or Malkin Protocol. And that was slightly modified, but is recommended here. The overgrowth syndromes, this was Jen Kalish and others dealing with mainly Beckwith-Wiedemann, but other Wilms tumor predisposition syndromes like Wagger and Dennis-Drash and Perlman syndrome, and as well as other overgrowth syndromes. We had the neurofibromatosis 1 and 2 group, and as a separate group, the neural tumors, neuroblastoma, retino, medullo, and rhabdoid. We had the GI cancer predisposition syndromes, the neuroendocrine tumors, mainly the MENs, but also the pheochromocytoma paraganglioma syndrome, leukemia predispositions, both ALL and AML, the DNA repair disorders, and then miscellaneous things like P10, Dicer 1, and the Noonan RASopathies. So there are recommended surveillance protocols. They're actually now being updated. Everything's a little bit on hold because of the COVID pandemic, but we expect to update those where necessary in the coming 3 to 6 months. So I'm going to talk about 3 syndromes, and I could talk about 10 or whatever, but I think it gets redundant. In most cases, the cancer predisposition syndromes are due to an inactivating mutation of a gene, usually an autosome. So it's usually autosomal dominant, and it's the decreased or lack of function of the gene that causes the problem. There are examples of predisposition syndromes where a gene is actually activated. So certainly the RASopathies account for that, and the hereditary neuroblastoma, where there's activating mutations in the ALK gene, the ALK receptor. So I'm going to talk about retinoblastoma. So this is sort of the prototypic hereditary neoplasm. It's a single gene that leads to a single cancer, at least in general in the pediatric age group. They can get second malignancies. And another single gene with multiple cancers, the Li-Fraumeni syndrome and TP53. And then finally, I'll talk briefly about Beckwith-Wiedemann syndrome, because this, unlike all the others where it's a DNA alteration, whether it's a mutation or indel or deletion or frame shift or splicing change, they all lead to some dysfunctional or truncated protein. In this case, the genes are fine, but the epigenetics that regulate the expression of the genes has changed. So in general, these are not inherited, whereas these obviously would be in an autosomal dominant 50-50 manner. So let's start with retinoblastoma. So this is probably well known to most of you, but it's just such a beautiful example of predisposition syndrome, because these patients have such a high risk of getting retinoblastoma compared to the general population. So most tumors develop by age 5, and the presenting signs and symptoms are leukocoria, like you can see here, the cat's eye, or this white reflex. Frequently, these patients are identified because of pictures taken at a birthday or family event, but they can have esotropia because they can't see and the eye starts drifting, or they can have conjunctivitis because of some alterations in blood flow. This represents about 3% of all the cancers we see in children under 15. So the prevalence of this disease is 1 in 30,000 live births. So it's pretty uncommon. But if you, and as I'll show you, it's due to mutations in the RB1 gene. But if you have a mutation in the RB1 gene, your chance of getting it is not quite 100%, but it's very high. It's over 90%, 90, 95%. So that means instead of 1 in 30,000, it's like 1. So that's 30,000 times more likely to get retinoblastoma. And the average child who gets retinoblastoma, 3/4 of them have bilateral disease, but they will have multiple tumors. So if you consider the average number of tumors is 3, they have almost 100,000-fold increased risk of getting cancer. There are about 300 cases per year. 60% are sporadic. These are by definition all but 40% are germline with a very high penetrance as well, and even unifocal. So it's still necessary to do genetic testing. So it's necessary to do genetic testing to be sure. The majority of the hereditary cases are bilateral. In some cases are trilateral, as it's referred to if they have a pinealoma or a tumor in the pineal gland. And this is just a pie chart showing that. So this is a figure taken from an early report by Al Knudsen, and this will lead us to the Knudsen hypothesis. So he analyzed the age at diagnosis and how many were not yet diagnosed by that age, because he's a statistician, and this is how he thinks about things. And he plotted the individuals with unilateral disease, which are the circles, and the bilateral disease, which are the squares. And if he draws a curve of best fit, this correlated with a single hit event, and this correlated with a 2-hit event. So he came up with the 2-hit hypothesis that with sporadic disease, you have normal chromosome 13s, you acquire 1 hit, you get a 2nd hit in a single cell, and that becomes a tumor. And with the hereditary form, you already have a mutation or inactivation of 1 copy of RB1. You get a 2nd one, usually a deletion. And so this happens much more quickly, and you have this very high chance of getting it. And in terms of pedigrees, it's autosomal dominant, although you can have individuals, obligate carriers that didn't apparently have the disease, whereas sporadic disease, there should be no family history. So this is just a diagram of chromosome 13. So the gene was mapped, RB1 was mapped to 13q14.2. You can see there the functional domains of the protein shown here and where mutations have been reported, and this is just a subset of them. They're all over the place. So there are some hotspots that occur more commonly, but there's not like everything occurs in this region or something. They're all over the place. So there have been several reports looking for RB1 germline mutations in patients that either had bilateral disease or unilateral disease. And interestingly, they use different techniques, PCR and MLPA and DGGE and next-gen sequencing and Sanger sequencing and so forth. And they all demonstrated at least 90% of patients with bilateral disease, and roughly 14–15% of those with unilateral disease would also test positive. The one test of these that were reported came from Arupa Ganguly at Penn and doing next-gen sequencing, and she found 97% of patients with as this would be 95 actually of 19 out of 20, but a much higher percentage, only one was missed. And she says from work she's done subsequently that most of the remaining patients, the other 5% or 3%, were likely a mosaic. So there still may be another gene that causes retinoblastoma, and we know that MYC-N amplification can cause it as without involving the RB1 genes as a sporadic change, but MYC-N amplification doesn't occur as a germline change. So anyway, as far as we know in terms of germline predisposition, RB1 is the only gene that's involved in this. So the surveillance is pretty much borrowed from this American Association of Ophthalmic Oncologists and Pathologists, the AOP group, and it's sort of just a sequential reduction in the frequency of doing intraocular or exams under anesthesia. So in the first 8 weeks, they do exams every 2 to 4 weeks, but non-sedated. Then they start sedating them, and they're done monthly for the first year, every 2 months for the next year, every 3 months, and every 4 months, and every 6 months. And although the recommendations are to stop after 5, there are a few patients have been reported who are somewhat older. Some people continue till 6 or 7 or 8 or so, but this is the official recommendations. In terms of looking for the pineoblastoma, to look for this trilateral disease, everyone pretty much recommends doing an MRI at the time of diagnosis. And some centers recommend doing an MRI every 6 months for 5 years. Most people think that's overkill, and they're usually present at the time of diagnosis if they're going to be, and particularly if they're getting chemotherapy, that can have an effect on the later development of a trilateral or a pineoblastoma. So as I mentioned before, there are a subset of patients who harbor a germline RB1 mutation are at risk for second malignancies. And this is estimated to be 15 to 20% over their lifetime. It's much lower than this in the pediatric age group, like up to age 20. But the types of cancer they would get are sarcomas of bone and soft tissue, like osteosarcoma, rhabdo, or other soft tissue sarcomas, malignant fibrous histiocytoma, melanoma, and melanoma can also occur. The risk is at least doubled or more if you get radiation therapy. So it's important to avoid that in their therapy if you can, if you know they have the hereditary form. But for older patients right now, the only recommended surveillance after the age of 10 actually is skin exams looking for melanoma by age 18, and education of patients to pay close attention to lumps and bumps, aches or pains that don't go away or can't be easily explained, and get them investigated. There's some who consider whole body MRI annually after age 8, but there's no consensus on this, and most people didn't think this was warranted. So next I will talk about Li-Fraumeni syndrome. So this syndrome was described by Fred Lee and Joe Fraumeni back in 1969. It was a hereditary cancer syndrome that largely was identified by patients like children with sarcomas and adults with breast cancer. But it's since been expanded quite a bit. And currently the core cancers that are associated with Li-Fraumeni syndrome are brain tumors of various sorts, including choroid plexus carcinomas, but also glial tumors and medullos. ALL, which is usually hypodiploid. There are sarcomas of bone and soft tissue like rhabdo and osteo, and adrenocortical carcinoma. And in older patients, they're at higher risk for breast cancer, colon cancer, and potentially other cancers as well. In their lifetime, up to age 60, 90% of women and 80% of men will get at least one tumor by age 60, and on average, they will have 3 tumors. And I know one of the patients we follow is 19 and has had 7 tumors, a couple of which have been presumptive second malignancies due to therapy. But There's no phenotypic feature of a patient with Li-Fraumeni except cancer predisposition. So you can't do a physical exam and tell who has it and who doesn't. So in 1990, David Malkin, working in Boston, identified mutations in TP53 as the cause of Li-Fraumeni syndrome. And David's sort of the international guru of Li-Fraumeni in children and adolescents, although there are many other people, including maybe some on the call, who are also extremely expert, and I'm sure much more so than I am. But the mutations that occur in the TP53 gene are quite variable, but there are certain hotspots. You can see certain places where they occur more often. And there's a lot of interest to identify genotype-phenotype correlations to determine if a change in the gene here is different than a change in the gene here. Are they more likely or less likely to get certain cancers, to get them at an earlier age, or whatever? The only one of these we can say with relative certainty is this R337H, or the Brazilian mutation that occurs in codon 37 of the TP53 gene. Most, not all, but almost all patients with R337H have some Brazilian ancestry. And they seem to have a somewhat more attenuated pattern for developing cancer, particularly in adults, but they're at increased risk for choroid plexus carcinomas and adrenocortical carcinomas. So we'd like to explore genotype phenotype in other diseases, as I'll mention at the end. So the initial Li-Fraumeni diagnostic criteria were a proband who had a sarcoma by age 45, a first degree relative with any cancer under 45, or a first or second degree relative with any cancer under 45, or a sarcoma at any age. So these were a little bit vague, and they've been modified by a variety of people, including Childre and Gonzalez, and the most recent I could find was the Boulgard 2015 version of this, which is summarized here. And this is in a JCO publication if you want to read it in detail. But this is their version of the Childre criteria. I won't read all this, but it's based on the family history, multiple, says primitive, I think they may mean primary tumors, and rare tumors or early onset breast. I should say this says they have Li-Fraumeni for therapy. So as I mentioned, children under age 20 are mainly at risk for 5 things: rhabdo, osteo, ALL, and brain tumors and adrenocortical carcinoma. And rhabdo, particularly if they have diffuse anaplasia, and ALLs if they're hypodiploid, and then any choroid plexus carcinoma, they're very likely to have a germline change. And the current recommended surveillance is to do the whole body MRI every year and a brain MRI as well. So the brain MRI is included in the whole body, but the neuroradiologists generally think it's suboptimal to detect subtle brain lesions. So that right now they're both recommended. And if the whole body MRI gets better in terms of resolution, maybe that can just be done. We also recommend abdominal ultrasound in between. So every 3 to 4 months up to age 18. And we used to recommend lab work to look for the adrenocortical carcinomas, and that's no longer recommended. So, and this is published in the paper by Kratz et al. In this AACR series of articles. So I'll show you 2 examples of the results of surveillance testing that was done for Li-Fraumeni patients following the Toronto or Malkin protocol, but this was not a randomized trial. So were people that underwent surveillance and those that refused to undergo surveillance. So in this particular first report in JAMA Oncology in 2011, it was really striking, 100% versus 20%. So all these patients were alive, even who developed a malignancy during the time they were being followed, either with or without surveillance. So this was very striking. They did a longer follow-up with more patients, and the results were still, it was, almost 90% versus 60% or so. It was still a significant difference, as you can see, and there were a lot more patients in here, but not many out here at the tail. And if you look at how the tumors were identified in these patients, that's shown here, and we'll just focus on the malignant subset, because there are, with this type of surveillance, you pick up incidental things that are either pre-malignant or not malignant at all, and even incidental findings. But of the malignant ones, 25% or so were picked up by the whole body MRI, so that's pretty good. And then it's up to 45% or so, almost 50% if you include the brain MRI. So clearly MRIs picked up almost half the cases. But clinical exam in some cases, colonoscopy, as well as the abdominal ultrasound actually picked up some, blood work when they did it, and then this was mammography. So those were the tests that really seemed to work. And obviously the mammography was really for patients that were older than our usual age group. Anyway, the point is, we'd rather pick up a grape than a grapefruit. If you can pick up a small tumor in the kidney or the liver or the muscle or the bone, you have a much greater chance of being able to resect it. You are likely to eliminate the need for radiation therapy. The amount of chemotherapy is likely to be less. They're less likely to be metastatic, better cure rate, fewer side effects, win-win. So that's how surveillance, regardless of the disorders, doing surveillance and picking up tumors early can achieve a tremendous advantage in terms of this mantra of more effective, less toxic therapy, because less therapy is needed. So finally, I'll talk about Beckwith-Wiedemann briefly, and then we can have questions if there are any. So obviously this was described by Beckwith and Wiedemann, and it's now considered sort of a spectrum, because the full-blown Beckwith-Wiedemann with 9 to 12 pounds at birth and big mouth, big body, big liver, big spleen, the abdomen doesn't close, they have pancreatic islet hypertrophy and hypoglycemia and macroglossia, and they can't close their mouth, they have trouble breathing, etc. So that's sort of the full-blown Beckwith-Wiedemann syndrome, but we now know this spectrum can include everything from just a big hand or foot or tongue, or big right arm and big left leg or whatever. So, and the testing for this is different than the traditional DNA sequencing that we do. So the cancers to which these patients are most predisposed are Wilms tumor and hepatoblastoma. And the hepatoblastoma risk is really in the first 3 to 4 years of life. So we screen up to age 4, and then Wilms tumor up to age 7 or 8. And this just shows a macroglossia, the ear creases, and sometimes pits you see. This shows the macroglossia, the umbilical hernia, because the abdomen couldn't close. Leg length discrepancy if one leg's involved and the other isn't. And this is a variation of that, where it's more girth than length. It can be either or both. So this sort of summarizes the type of epigenetic changes that occur in patients with Beckwith-Wiedemann. And typically, most people have a paternal pattern of methylation and a maternal pattern of methylation. And the paternal pattern favors growth, and the maternal pattern suppresses growth. So what happens in Beckwith-Wiedemann is you have more of this and less of this, more of the paternal and less of the paternal. So if there's hypomethylation at the maternal locus here, that accounts for half of them. So they have the paternal pattern. And similarly, you can have hypermethylation of the maternal IC1, and you can have this pattern with IGF-2 driving the growth. So these two aren't as prone to causing cancer because it's either one or the other. But with uniparental isodisomy, you actually have 2 copies of the dad's DNA as well as his imprinting pattern. So the entire locus is involved. And these patients have the highest risk of developing cancer. And this is the percentage, not the risk of cancer. The risk of cancer is about 5 to 10% overall. It's about 20 or 25% in the isodisomy patients. Interestingly, you can have inactivating mutations of CDKN1C, and that's a fairly uncommon genetic cause of Beckwith-Wiedemann, but this is the type that could be heritable, and it accounts for maybe at least half the cases that are inherited. As a caveat, I saw one family where a child was born who had a big left arm and a big right leg, and she had the IC2 pattern of methylation. And then she had a sibling born 2 years later who had a big left arm and a big right leg. She had exactly the same pattern in the child, even though it wasn't caused by a germline change, at least that we could identify. So anyway, strange things happen. Sorry. So here's the surveillance protocol for the Beckwith-Wiedemann hemihypertrophy, and we apply this protocol to other disorders where there's increased risk for Wilms tumor and or hepatoblastoma. So the overall risk, I said, is 5%, highest in isodisomy, lowest in IC2 methylation. We do an abdominal ultrasound, full abdominal, every 3 months, starting at birth or at diagnosis until age 4. And then we also do AFP testing, again, to look for hepatoblastoma, starting at birth or at diagnosis and until age 4. And then these stop, but the ultrasound continues as a renal, adrenal ultrasound from age 4 to 7 every 3 months, and then we stop. And again, some people go on to 8. I just had a telemedicine visit with a patient this morning, that is going to go on till 8, in part because another doctor as well as the parents want to continue, so that's fine. Patients with CDKN1C, and this is kind of soft, but it does appear that some patients with CDKN1C mutations may also be at increased risk for neuroblastoma. So getting urinary catecholamines at these every 3-month visits would be worth doing. But there are no other good genotype, phenotype modifications at this point. And as far as we know, there's no risk of cancer at older ages in these patients. It's just the childhood cancers up until age 7 or 8. I do know there's a Beckwith-Wiedemann patient we followed who stopped at age 7 and developed Wilms tumor at age 9. So it does occur, but it's a pretty rare thing to happen. So this is the final slide, I guess, to talk about future direction. So there's a lot to be done in this field, and I'd recommend any junior investigators looking for things to potentially get into, this would be an important one to consider. So new gene discovery. As I mentioned, there are patients that fit a pattern like a syndrome, like they have juvenile polyps. And juvenile doesn't mean it occurred in a juvenile, it means a particular type of hamartomatous polyp as opposed to adenomatous polyp. And there are patients that have that and look like they have the syndrome, and it's even familial, yet they do not have changes in SMAD4 or BMPR1A, the 2 genes that have been associated with this disease. And there are other examples. Not everyone with what looks like Li-Fraumeni family history will have a change in TP53. The vast majority do, 80, 90%, but not all. And the same thing could be said for many of the other syndromes that we deal with. So, and there are also syndromes for which we don't have a gene to look at. Like I said, hereditary Hodgkin disease. I've seen at least 3 families with hereditary Hodgkin's, and we don't have a gene to look at except for potentially STAT1. So there's a lot to be done here. There also are the lower penetrance genes that we haven't focused on so much because of these high penetrance genes where it's 1,000-fold, 10,000-fold, 100,000-fold, but there are likely some that are 10, 50 to 100-fold increased risk where there are a lot of more genes to be identified. Oops, sorry, wrong way. The next is genotype-phenotype correlation. So there are some examples of this, but I think because of the the meeting we had in 2016 and the publications in 17 with people doing this more consistently, with more people doing testing of tumors and now testing of the germline, we're going to have a much larger database to look at things like, does a mutation in this area differ from a mutation in this area, or is a missense different than a nonsense, or in a particular domain, does it make a difference? A DNA binding domain, a dimerization domain, a kinase domain, and so forth. So I think we'll be looking for ways that we can personalize the risk and the recommendations for surveillance based on that sort of information. Third, a lot of us are interested in novel surveillance tests. There are likely, in addition to things like serum AFP or urinary catecholamines or things like that, there are probably other markers that we could identify in the blood or urine that might be useful for picking up tumors early when we see a pattern of something increasing. You know, it may not be a protein, it could be a carbohydrate or a lipid or something else, but there likely are other tumor markers to be found. A lot of people are looking at circulating tumor material, I would say. So people are looking at tumor cells, at DNA, at RNA, at exosomes to try and identify that. And some have developed very sophisticated microfluidic ways to capture the DNA from tumor DNA from normal or tumor material and to analyze it. And also changes in the microbiome. The microbiome in the gut clearly plays some role in development of colon cancer. The microbiome in the mouth plays a different role in the development of oral cancers. And the changes in the microbiome in the gut or potentially elsewhere also influence our immune system and can affect the immune response to malignancy and can affect malignancies at other sites, not just in the gut. A fourth thing is prevention strategies in high-risk groups. So people are starting to evaluate drugs, such as, let's say, mTOR inhibitors in patients with activated the PI3 kinase AKT mTOR pathway in P10 syndrome, or drugs that block MEK or MAP kinase in the RASopathies and so forth. There are some other drugs that more directly influence the levels of P10 and can increase the levels of P10. So instead of decreasing, getting rid of something or blocking something, you can actually increase the protein half-life of P10 with certain drugs, indole 3-carbinol. There may be dietary things we can do in microbiome transplants. If you have bacteria in your gut that we know increase the likelihood of developing polyps and cancer, and we can give you a gut purge and reinstitute favorable bacterial flora or probiotics that are favorable, you may be able to delay or reduce delay or whatever, maybe even prevent the development of some colon cancers. So that's something we'd like to be able to do. So there are a lot of things related to drugs and diet and lifestyle and microbiomes of your gut and your mouth and other places, maybe skin, that could be useful in trying to prevent cancer in high-risk individuals. And if these can be shown to work, then potentially, depending upon how expensive or toxic or whatever, they could be applied more broadly. And finally, we are in our program engaging the psychologists to study issues around the impact of the genetic diagnosis and testing, the ethics of decision-making about whether to get tested, whether to follow a surveillance protocol and so forth. And also disclosing adult cancer risk to children, like when is it the best time? Do you wait till they're 18 or do you do it while you have them and so forth? So there are a lot of things that could be addressed there. And I'm sure there are more. These are just a subset that are obvious to many people. But anyway, I think there's a lot of exciting thing to be done in this overall field. I encourage some of the junior people who aren't wedded to something or are working in something that their mentor is working on and they don't see an obvious path forward that's independent to consider working in this area. So that's it. I'm happy to ask any questions. I hope most of you are still awake, and I will stop screen sharing if I can get this. There we go. So, Jen, are there any questions?
You do have one question in the chat. How good is compliance for predisposition surveillance? What are factors that impact compliance?
So that's an excellent question. And I'm not just saying that, it is. And that's something else that our psychologist team, somebody we're just recruiting now, is very interested in. So, because I think compliance is critical. It's critical with cancer therapy, it's critical with diabetes management, it's critical with everything. And in this area, if they aren't complying regularly, we're not going to pick things up early, and they're going to end up presenting with clinical symptoms. So, so we need to work on compliance and what the barriers are. We know that some of it is insurance and cost. Some of it is the difficulty of busy parents to do something every 3 months or every 6 months even. If they're both working and it's hard to get the kids in and they're in school and it's hard to find the best time to do some of these things. But we don't really have a good idea, particularly in this area, what affects compliance. So it's something we will be studying. There are a lot of things we can think of might contribute to compliance. The kids don't want to get stuck and the parents don't want to take them, or they don't want to put them to sleep because there may be some risk of that, or it's costly because they have to pay a deductible every time, or their insurance won't cover it, or they're just too busy, or whatever. So, or it's hard to get here and to get an exam. There are a lot of things that, but we don't know what are the real major causes. So it's very important to figure that out if we can.
A couple more questions have come in, Garrett. One is, have you looked at any predisposition disorders involving BRCA-related cancers in children?
So we're not seeing those patients very much. There are ones that predispose to leukemias and lymphomas. In general, they're ALLs or AMLs, a lot of AMLs. We have a team that includes Suzanne McFarland, who's very much focused on the GI cancer predisposition syndromes, and our division chief, Steve Hunger, who ran the predisposition program in Denver before he came to CHOP. And actually, Steve sees most of those, although a lot of them come through us, and then he's just ends up being the physician that partners with one of our genetic counselors to see them. So offhand, I can't think of any, but Steve would be the one who saw them. So I should know that off the top of my head, but I don't. I haven't seen any.
Another question came in. Is there any evidence of variation in genotype-phenotype correlations in predisposition syndromes across different race and ethnic groups?
So another excellent question, and one that I do not think has been addressed. I think people are initially focused on just determining if there are any at all in the general population, and I think once, if you establish that there are some, then you could look. But I think it's a very good point, because maybe if you look at the population as a whole, you won't see any obvious genotype-phenotype correlation. But if you look in African American or Hispanic or Asian or other ethnic subgroups, you might see something in them. So I think it's an excellent point that needs to be looked at prospectively in parallel, not after we figure out the genotype-phenotype, because I think we could pick something up looking at those ethnic subgroups that we might miss if we just look at the general population.
Thank you, Garrett. A couple more questions have come in. By the way, I want to thank you for doing this talk today. I had trouble getting on at the beginning, but we really appreciate it. You've been a friend to Alex's Lemonade for a long time, friend to Liz and I for a long time, and we appreciate you giving us the time and talent today.
It's been my pleasure.
Okay, next question is for patients with germline mutations that are associated with childhood cancers, but that do not have a well-established surveillance guidelines. How do you decide on a surveillance plan?
Oh, so another very good question. So I've been interested in predisposition for a long time. Like when I was an intern and resident in St. Louis, I was following a family that had 2 children with neuroblastoma. One died and one is still alive with multiple ganglionomas. Their father developed neuroblastoma at age 44 and had metastatic disease and died. And that person and that family ended up having an ALK mutation. We now know, but I had no idea then. So I've been interested a long time. I hired Kim Nichols in '99 to establish a cancer predisposition program at CHOP, and she did. And then she was recruited to St. Jude to set up one there, and so I took over. And it became evident to me that there weren't a lot of well accepted or agreed upon surveillance protocols for many diseases. I think Li-Fraumeni, Beckwith-Wiedemann, maybe retinoblastoma, neurofibromatosis. There were some where some group or another that dealt with these patients had come up with some recommendations, but for many, there weren't. Like if you say ASXL1 or NKX2-1 or fumarate hydratase deficiency or things like that in the hereditary myoma and hereditary renal cancer and renal carcinoma syndrome. So what we did was identify the 60 or so most common syndromes, and this was a team effort with David Malkin, Sharon Plon, Josh Schiffman, and Kim Nichols, and we divided these into those groups that I showed, the 9 groups, and we asked people to come to that meeting with recommendations, because in many cases there weren't any. But if you say, if there's an increased risk in patients with a particular syndrome like Edwards 18q trisomy, and they're at increased risk for Wilms tumor, well, those are Wilms tumor protocol that is established for Beckwith-Wiedemann, so we just follow that unless there's a good reason not to. It turns out in that, or to do anything different, it turns out in that population, they may actually get renal cancer for a longer period of time. So maybe surveillance would need to be extended, but again, it's a very serious syndrome and many don't survive beyond the first year of life, and maybe worrying about a low risk of cancer is not worthwhile. But we try and use a protocol if it seems applicable that's been developed for another syndrome but has a similar disease. So let me give you another example. For familial adenomatous polyposis, only about 1% of patients with FAP will get hepatoblastoma, but 10% of patients with hepatoblastoma may have a germline change in FAP. So we use the Beckwith-Wiedemann syndrome protocol for AFP and abdominal ultrasound every 3 months for 4 years. So we use that for that population of patients. So we sort of borrow where we can from one and use that unless there's a reason to do something differently. Either start sooner, do it longer, do it more often, less often. If something is just completely out of the blue, we sort of come up with what would be the least invasive, most informative surveillance tests we could do, and factoring in not just the ability to detect things, but also the ability to minimize any discomfort to the patient and cost and so forth. So we try and factor all that in developing a protocol. So I'm sure we'll be expanding the protocols that exist for additional syndromes that aren't part of the top 60 that are included in the ACR reports, but I think it's best to do it if we can get some consensus or agreement around that. So whether you're in France or Germany or England or Spain or whatever, or if you're in anywhere in the United States or Canada or Japan or Australia or China, that people will do the same thing. So we try and get some consensus if we have new syndromes, and we likely will have another ACR meeting maybe next year. I mean, that may be on hold now because of COVID, but we plan to have an additional workshop to catch up with what is being done, evaluate it, see if it needs to be changed, see if there are any new things that need to be added, and that would be a way to get them into the pipeline.
Okay, Garrett, thank you so much. One last question. How common is it to see a patient showing some signs of a cancer predisposition syndrome, but never actually develops a type of cancer?
Well, that's it varies a lot by syndrome. So things like retinoblastoma, 95%, Li-Fraumeni, 90% will develop a cancer. But there are patients even with both those diseases that never develop a cancer. There are other syndromes where they absolutely don't always develop a malignancy. So there are more attenuated forms of juvenile polyposis, where like half the patients will develop colon cancer, many will develop polyps, but not everyone does or develop enough polyps to be called juvenile polyposis, or not everyone with Dicer-1 germline change will develop cancer. We see patients with P10 syndrome, where the parents have P10 and were not diagnosed, and they don't have a cancer, and they're already in their 30s or 40s or whatever. So it certainly does occur. So the absence of a cancer doesn't rule out that they have the gene. You have to do the testing, and there's penetrance and expressivity. Penetrance is, do they get something, yes or no? And expressivity is, they got it, how bad is it? Or what are the manifestations of it? So penetrance is not 100% in these disorders. So there clearly are people that don't develop any cancer, even in their lifetime.
All right, that was the last question. Someone just said thank you for all the great information, for the amazing work you're doing. But Garrett, again, appreciate your time today. Appreciate everybody tuning in. Appreciate Jen, who put this talk together. And this is going to be the first in a series, so look for more. We're doing at least one a week, I think, for the next 5 weeks. We may try to squeeze more in. But thank you, Garrett.
Okay, my pleasure. Thank you all for tuning in. And I'll sign off. Bye, Jay. Bye, Jen, and thanks for all your help in helping to get this started.
Bye, Garrett.
Thank you, Garrett.
Bye.